Hello and welcome once again to ECG signs of ST elevation myocardial infarction. As we said earlier on, in STEMI, there is a complete occlusion of the coronary artery, and so it is eminent that we acquire an ECG within the first 10 minutes of arrival of the patient to the emergency room, because it is going to help us with our recognition of the condition as well as initiating treatment for this condition. We've already looked at the various types of STEMI, and so in this case we are straight away going to look at our case scenarios and how to identify the ST elevation. So in this scenario, we have a 60-year-old woman who is brought to the emergency room 5 hours after symptoms of chest pain. So what must we do? Quickly, we must take our ECG within 10 minutes and we must assess this patient and give aspirin. So in this case, we gave 162 milligram of aspirin per hour. Then on the ECG, we found a large anterior STEMI. So antiplatelet therapy was also initiated. In this case, we gave clopidogrel of 600 milligram per hour. Now, what do we need to know about anterior STEMI? Quickly, this anterior STEMI results from occlusion of the left anterior descending artery. Now, when this happens, it carries the worst prognosis of all the infarct. Why? This is because it is this area of the LAD is a very large area, and so the prognosis is not so good, because a large infarct area is going to be seen. And so how do we recognize this on an ECG? On an ECG, what we are going to find is there is going to be an ST segment elevation on the anterior late. We know the anterior late. So specifically, we should be looking at places such as V1, V2, V3, up to V4. Sometimes you can even see them on V3, V4, specific for the anterior legs. So that is it. Then we may also, find some ST elevation in the precordial legs from V1 to V6, and also some Q wave, pathological Q waves may also be seen. Then we may find a reciprocal St Depression in the inferior legs in standard leg 3 as well as AVF. So this is how we recognize anterior wall STEMI. So quickly, what we need also to know over here is that the infarct pattern in anterior wall is named according to the maximum or the maxima led with the ST elevation. And so we may have septal, anterior, anteroseptal, anterolateral, as well as extensive anterior or anterolateral. So when it is septal, you are going to find it in V1 to V2, and as you can see over there. So let's quickly look at some ECGs and how to interpret them. So quickly, what do we see on this ECG? On this ECG, since we are looking at anterior STEMI, where must we focus? We must be focusing on the precordial legs, V1 to V6, and identify the lead with the most highest ST segment elevation. So on this ECG, we find ST segment elevation maxima in the anteroseptal legs 1 to 4. So anteroseptal legs, so we have the septal legs, so we have V2 over here. So we have ST segment elevation over here. We have also in V3. Then we also have in V4. We may also have it, or we may also see it in V5 and V6. But as you can see, it is maxima in V2, V3, as well as V4. What else can we see? We can also see Q wave, pathological Q wave, in V1 and V2. So look at V1 and V2. So these are pathological Q waves. What else are we looking for? We are also looking at ST depression. We said we should look for reciprocal ST depression in inferior legs. Are there any ST depression in inferior legs? Yes, but it is very subtle. So look at the standard leg 3 and so these are standard leg 3. This is the isoelectric line. This is the isoelectric line, and as you can see, there is a minimal ST depression in standard leg 3 as well as in AVL. It's not so prominent, but there is a minimal ST depression in this inferior legs. What else? We can also find a hyperacute T wave, or when we say hyperacute, I mean a peaked T wave, very long T wave in standard leg 2 here, and also in V4. Sorry, in V2 as well as in V4. So as you can see, this is the T wave. This is another T wave. So we call this a hyperacute T wave, and also as you can see, this ECG is pointing to a hyperacute anteroceptor STEMI. Anteroceptor STEMI because we have V2 involved and the anterior legs, which is V3 and V4, being the most legs with the highest ST elevation. Let's look at another one. In this second ECG, what do we see? We are still looking at anterior STEMI. So what do we see? We have hyperacute T waves from V2 to V6. So you can see. So we have V2, V3, V4, V5, V6. But we are looking for the ones with the highest. And so the most marked, T waves, as we can see over here, is V2 and V3. So as you can see over here, we have this as well as this. What else do we see? We also see that the height of the R wave is almost completely missing. The R wave over here is almost completely missing. Over here, we can't even see the R wave over here. A very short R wave over here. Then also in this ECG, actually we are looking at a first degree AV block. And how do we find the first degree AV block? We are finding prolonged PR interval in almost all the leads over here. And we can also find premature ventricular contractions. These are premature ventricular contractions over here. These are premature ventricular contractions. So these are premature. Yeah, these are premature ventricular contractions over here. And once we have this in this patient, then it tells us that the myocardium is very irritable, and so this patient is at risk of developing ventricular fibrillation. Now let's look at, do we have another ECG? Yes, we have another ECG. So in this ECG too, what do we see? We see ST elevation in precordial leads, from V1 to V6, as well as in AVL. So over here, so you see ST elevation over here. Look at V2. So V3, V4, V5, V6, there are ST elevations over everywhere, as well as in standard lead 1 and AVL. Look at standard lead 1. You may not see so well, but this is the isoelectric line, and you can see it over here that is elevated. So this is the isoelectric line, and as you can see, it is elevated over here as well. And also in AVL, this is the isoelectric line, and you can see the elevation of the ST segment. Also, we have minimal reciprocal changes or depression in inferior legs. I told you in anterior legs we must look for reciprocal ST depression in the inferior legs. Where are they? This is inferior leg, standard leg 3. So this is the isoelectric line, and so we can see there is a depression in ST segment. Also in AVF, this is the isoelectric line, and so you can see there is a depression in the AVF over here. Now, what else can we see? I think basically this is all that we can see. Now, looking at the end of this ECG, looking at the end of this ECG, we can see that there is a premature ventricular contraction in which the R wave is superimposed on the T wave at the end over here. And so when this happens, it puts this patient at a higher risk of also developing, ventricular arrhythmias. So this is it. As you can see, the R wave is on the T wave. Yeah. I think that's all we can see in this ECG. Quickly, let's look at our last ECG. What do we see? There's an interesting one. In this ECG, still we are looking at anterior ECG. So anterior STEMI. So where are we looking at? The precordial leads, and we must find pathological KO as well as a reciprocal depression of ST segment in inferior leads as well as AVF. So what do we see? Let's start. We can see a massive ST elevation, which we call tombstone. So this is what we call the tombstone morphology. Look at this ST elevation starting from V1, V2, as you can see over here, a massive ST elevation. You can see it's all over the place. So we call this tombstone. You can see it in all the precordialates over here. You can see it, and it's throughout. We can also see it in AVL over here, as well as standard lead 1. And so, where do you think the occlusion is? We are having all the lateral leads occluded, all the anterior leads occluded. We are having all the lateral wall infected, as well as the anterior wall, as well as. So, this is what we call tombstone. And this pattern is usually seen in proximal LAD occlusion. As I showed you, the LAD is a branch of the left coronary artery. So if there is any occlusion in the proximal area of this LAD, or as a matter of fact in this left coronary artery, then the whole area beneath which the LAD supplies is going to be, infected, or is going to die. So this is going to show a large territory infarction, and this will pose a poor left ventricular ejection fraction in this patient, and this patient is likely, to have a cardiogenic shock, and death will ensue in this patient due to this cardiogenic shock. This is because the whole area is infected, and also and so the left ventricle is unable to pump very well to push the blood from it into the system, and so cardiogenic shock may ensue and the patient may die. I forgot to show you that there is a reciprocal ST segment depression in the inferior lead in this ECG. So you can see in standard lead 3 as well as in AVF, you can find ST segment depression. So this is all that I have for you, and I hope it helps you, and I hope you're able to understand. Our advice that you watch this video continuously over and over again, and it is only when you do this that you get adapted to reading such ECGs. Thank you very much for your attention. Bye bye.